So this is some data which we're going to publish, we're going to share, and it's the manuscript is underway. We're going to share this data in the Canadian liver meeting later this month. That we used the primary care healthcare database and assessed how many patients were eligible for NAFLD screening detected by obesity, and we found only 7% of patients who were eligible for NAFLD screening were only being screened. So that's a very poor screening rates we are seeing in Canada. So using this database, we were able to detect around 1,000 patients of pediatric NAFLD across Canada. So this is the largest cohort that has been published ever so far. And we found that around 10% of these patients have ALT that is more than 80, which has been corroborated with the diagnosis of advanced NASH. And most of these patients were obese. They were male, as seen in trend elsewhere in the world. They're more in the urban settings and more pronounced in between the ages of 13 to 18 years. That's what we clinically see. So coming back towards NAFLD, a bit of natural history. The data in pediatric world from the natural history standpoint is not as clear as adults, but we feel that probably children have sort of an aggressive disease. Around 15% of children might have stage 3 fibrosis or even higher at the time of diagnosis. So the longitudinal data is not there, but what we have found that if you take the placebo control arms of clinical trials that have been done in pediatric world, it's said that resolution of NAFLD is extremely uncommon. Around 1/3 of these patients might worsen, around 50% might improve, but we have to understand that placebo is not absent of treatment, because all of these children are given lifestyle advices, which is currently the recommended therapy. So it's not giving us a clear idea, but it clearly says that resolution is very rare. The only available data in pediatric NAFLD natural history comes from Sweden. So this was a publication that was done last year, in which they compared 700 patients who have NAFLD and they matched them with controls, and they found that patients who have NAFLD, every one child, like it translates to basically one additional death per 15 children with NAFLD who have been followed for 20 years. So it overall translates into one additional cancer death for every 32 children with NAFLD, one additional cardiometabolic death for every 50 children with NAFLD, and one additional liver-related death for every 56 children with NAFLD over this span of 20 years if you longitudinally track them. So this is a significant problem leading to a lot of mortality and morbidity down the road. So how do we diagnose these patients? As I said initially, it's a completely asymptomatic condition. You need to screen. So this is still a diagnosis of exclusion for us. And then you can assess their steatosis and fibrosis using various measures. And there are a bunch of exclusionary criteria which we use when we label patients with NAFLD in our clinics. And just a few slides about what we currently do and what are the fallacies around them. So currently the guideline says to use ALT. So it's extremely important when a physician is checking an ALT on these children, they should always use the cutoff that is age and gender specific rather than the lab specific. Because if a lab's value is 40, it's already twice the limit of normal for a child who is 9 years of age. And then unfortunately, ALT is not a very sensitive marker. It is not diagnostic for NAFLD, neither it is diagnosis for NASH. But we know that there have been some data around that show that if your ALT is over 80, there is a high chances of having NASH in these children. And then in Canada, we're fortunate we have a caliper database which we can use whenever we assess ALT level in children. We can always compare depending on their age. But as I said, normal ALT do not rule out NAFLD. So you have to understand the clinical condition and use other modalities to diagnose NAFLD sometime in children. One of the most common one is ultrasound, which we can detect steatosis, which is inexpensive, widely available, but it's not a great modality for diagnosis of mild steatosis. And if your liver fat is less than 30%, you will not be able to detect it. Or if you are if you have severely obese, morbidly obese, then it also reduces the sensitivity. Over the past 5 to 6 years, there's been a lot of event on MRI utilization in diagnosis of NAFLD in adults as well as pediatrics. So this is a new advent called as MRI proton density fat fraction estimation. It has shown to be having good sensitivity and specificity in pediatric as well as adult for diagnosis of steatosis, but unfortunately it's very limited. It's not easily accessible, and it also cannot rule out NASH or fibrosis, but we can definitely add something called as MR elastography to it, which can help us give some non-invasive assessment of stiffness or fibrosis in these children. And then liver biopsy, it's a sort of a controversy when to do these liver biopsy in these children. When the prevalence of this condition is 10%, you can't start biopsying everyone, because there's a huge there is a risk of invasive modality complications associated with it. And liver biopsy is sometimes your liver is just patchy, you will not be able to pick up the right area. There are a lot of bias around that. But there has been some suggestions from NASCAM group that if you're thinking about advanced NASH or fibrosis, you should consider biopsy. Or if you're planning to start some therapy, then you should also think about biopsy in these children. Coming to treatment, the the goals are is regression of NAFLD and resolution on histology if that happens. And currently, the only available treatment is lifestyle management, which incorporates diet and physical activity. And at this point, I'd like to introduce Inez Martinez, she's a clinical dietitian working in pediatric gastroenterology and hepatology division at Hospital for Sick Children. And Ines has extensively worked with children with NAFLD, and she's going to be providing some evidence-based approach to dietary management in children with NAFLD, as well as some practical tips around that. Thank you. And then I'll take on once Ines is done to complete my presentation. Thanks.